will leave the webinar very soon to our colleague, Dr. Rabab Safwat. Dr. Rabab Safwat is, I'm so honored to have her tonight. I'm so proud of her. She is my colleague from Alexandria. I'm so proud of that, you know, and Alexandria is my university. She's graduated from Alexandria University, and she earned her medical doctorate degree, and she is one of the excellent experienced anesthesia in intensive care medicine. Dr. Rabab Safwat Ibrahim is the moderator of tonight. I have all the floor for you. Thank you so much.
Thank you very much, Dr. Mahdi. Good evening, everyone. On behalf of the Educational Board Mega Online Anesthesiology course, I would like to welcome the speakers, moderators, and attendees tonight to this creative and prestigious continuous opportunity to deliver not only an update in the field of anesthesiology, critical care medicine, and pain, but also to gather unique speakers from all over the globe. Thank you very much, Dr. Mahdi and the team for all the effort behind this distinguished course. It's always a pleasure for me to join you. Tonight, we have a very interesting topics presented by our outstanding speakers. Please allow me to welcome and introduce Dr. Sharmili Sinha. Dr. Sharmili has got an MD in anesthesia, DNB, EDIC, FICCM. She's a senior consultant, critical care medicine, Apollo Hospitals, Bhubaneswar. She's got an area of expertise in neurocritical care, and she is going to shed some light tonight on the management of intracranial hypertension in traumatic brain injury. Dr. Sharmili, please go ahead.
Thank you, Dr. Rabab, for your kind words of appreciation. And at the outset, I'd like to thank Dr. Saad and Team Mega for this wonderful opportunity to present on this prestigious and popular academic platform. So, and it was really indeed a delight to hear Professor Dr. John Doyle on this very interesting topic. So next we'll be talking about a very different topic, yet very important and relevant to our clinical practice in intensive care unit, about severe traumatic brain injury and management of intracranial hypertension. So tonight we are going to talk about the severe traumatic brain injury. Now, friends and colleagues, as all of you would agree with me that road traffic accidents actually across the globe have started. So the road traffic accidents and the polytraumas associated are on the rise across the globe. And because of that, this traumatic brain injuries and the polytraumas, there is a lot of rise in or increase in the incidences of morbidity and mortality. And also it has led to loss of functional years, especially in the younger populations. So in the next around 20 to 25 minutes, we'll look at what are the issues associated with this severe traumatic brain injury and how best we can manage this to have a most favorable outcome. So these are the learning objectives of this evening on the topic. So now how we classify this traumatic brain injuries. The most simplest one, which have been using for years together or decades together, is the Glasgow Coma scale. So based on that, it is classified into mild, moderate, and severe. The severe one is that where the GCS is less than 9. Now, all of us would have probably were aware or familiar with the Brain Trauma Foundations. It is a foundation actually which has been working on the recent data or the trials and the best possible evidence that is available in literature in the field of trauma and head injury aspects. And they have devised various grades of recommendations regarding management of severe traumatic brain injury and intracranial hypertensions. Now, according to them, the level of recommendation have been divided into these 3 categories: high quality, moderate, and low qualities. Now, our discussion will mostly revolve around this guidelines or the recommendations from the Brain Trauma Foundations, and also my experience of 17 years of neurocritical care management. So let's have a quick look at the basic or recapitulate the basic physiology of brain and the intracranial compartment. Now, brain is a soft tissue which is tightly and beautifully encased in a hard fixed volume compartment, that is the skull. Now, if you look at this intracranial component, these are mainly divided into 3, where brain comprises around 80% of the volume, followed by blood volume, which is around 10%, and also cerebral spinal fluid, which is around 10%. So now you look at this picture, this is the brain, this is the arterial blood, and this is the venous, and this is the CSF. Now when, and this internal volume almost remains fixed between 1400 to 1700 mLs. Now when there is an abnormal pathology arises, like there is a hematoma, tumor, contusion, or cerebral edema, this is depicted as red here, this starts rising, the pressure starts rising, and there is decrease in the volume of the venous drainage and also the CSF. Now, when there is an enormous rise in the size of the pathology, the pressure precipitously rises and it leads to a decompensated rise in the intracranial pressure. So now coming to the management of severe traumatic brain injury, all of these will start definitely with the basic trauma resuscitations when a patient present to the emergency department. So a case may be having isolated traumatic brain injuries or maybe a part of polytraumas, like where they might be having various degrees of either cord injury or a chest or blunt abdomen traumas or long bone fractures. So they got to be resuscitated first of all, according to the ACLS protocols as desirable or feasible in the center. Sorry. And trauma resuscitation is actually highly recommended within the initial golden hours, because there is a direct relation with the best of outcomes, which is related to the appropriate resuscitations in the initial phase. Now, it is very imperative and essential that the secondary injuries are also prevented in this initial times, in initial hours, which might have an impact, adverse impact in the later on period, if it is not given proper attention in the emergency department. Now, our management of severe traumatic brain injury and the intracranial hypertension will be divided among the subcategories, which we'll be discussing subsequently part-wise. So now coming to fluid management. Now, any patient of trauma or polytrauma, when they comes to the emergency department, if there is hypotension or if there is a state of shock, unless otherwise proven, it is considered to be hypovolemic shock. And for that matter, the first and foremost is to resuscitate them with fluids. And it is now consensus and universally accepted and acclaimed that crystalloids are the best preferred fluids for resuscitations. Colloids are to be avoided, and they have been very clearly proven to provide no further benefits. The famous SAFE trial has found increased mortality in patients who actually received albumin compared to saline in this subset of populations who had traumatic brain injuries. Now again, not to forget that glucose-containing solutions are never ideal for patients who have brain injuries or head traumas. And during all phases of management, tight blood glucose control, something ranging from 110 to 180 mg/% is desirable for these patients. Next comes important is regarding the anesthetics, analgesics, and sedatives. Remember, all these patients who have got some kind of trauma, either isolated traumatic brain injuries or polytraumas, they are in a lot of pain because of the musculoskeletal injuries that might have happened, and also their body is affected to various degrees. So this pain, when it is uncontrolled, there is agitation, and it all leads to rise in the intracranial tension. So it is very essential that there is good analgesia and sedatives are provided to these patients, and especially also many times these patients are under the influence of alcohol or other drugs. So they need to be quietened, they need to be provided adequate analgesia. Now, barbiturates for a long time have been actually used in the history to control intracranial hypertension. But it is now well understood that they have a lot of potential for complications, mainly hypotension, especially if the patient has got underlying fluid deficit, which has not been addressed, if there is an underlying cardiac dysfunctions, and many times patients, when they present to the emergency department, it may not be known if they have an underlying cardiac pathology. And also, in addition, they give rise to or lead to increased VQ shunting or intrapulmonary shunting, thereby increasing the chances of hypoxia. So barbiturates are not very good agent to be used in all traumatic brain injury patients who have got raised intracranial tension. So let's look at the grade of recommendations in these patients regarding barbiturates. Administration of barbiturates to induce burst suppression as prophylaxis against development of intracranial hypertension is not recommended. So I repeat or emphasize that its use as a prophylaxis against development of intracranial hypertension is not recommended because of the side effects. However, it can be used to control the elevated ICP, which is refractory to maximum standard medical and surgical treatment. So it does have still a role in the refractory raised intracranial pressure, but not as a prophylaxis measure. Now, what about propofol? Propofol, actually in our practice, we have found that it is a good drug when there is, it helps in sedating the patient and also to control the blood pressure if it is inadvertently high in these patients when they are on the ventilator, and if they're fighting the ventilator for a variety of reasons. Of course, analgesics have to be provided, but different kind of studies have been studied, and they have not been recommended for improvement in mortality or 6 months outcomes. But caution is also required, as high dose propofol can produce significant morbidity. Especially in our practice, we find that if the propofol is continued beyond a period of 12 hours, it leads to the propofol infusion syndrome of various degrees. It may be mild, moderate, or severe, and in the severest form, actually it does give rise to rhabdomyolysis, hyperkalemia, metabolic acidosis, and also some degrees of the acute kidney injury. And also it can propitiate hypotension in patients who have got underlying cardiac dysfunctions or bradycardia. So hemodynamically also one have to be very cautiously monitoring if you are starting propofol for these patients. Hence, so it has got a level 2 recommendations for its use. Now coming to the ventilation therapies. Now ventilation and intracranial pressure are very closely related. Now most of these patients who have got severe traumatic brain injuries are obtunded, and thereby they have a compromised respiratory drive and functions, and hence they remain at a risk of aspirations. So all of these patients ultimately end up having elective intubations in the emergency department or in the intensive care unit. Now, when we are ventilating these patients, there is a very close relationship between cerebral blood flow and the brain's metabolic demands. If you're hyperventilating these patients, thereby trying to achieve low carbon dioxide levels, it actually leads to low cerebral blood flow. When cerebral blood flow decreases, it leads to cerebral ischemia. So the brain's metabolic demands are not met with, so the dysregulation or the dysfunction ensues. On the other hand, if you're hypoventilating these patients, there is rise in carbon dioxide, and it leads to increase in the cerebral blood flow, that is called cerebral hyperemia, and in turn it gives rise to high intracranial pressure. And it is also widely accepted and observed now that cerebral metabolic rate is actually variable in different parts of the injured brain. It's not constantly high or low in any part. It is quite variable across various parts of the injured brain. So there is a consensus to have a very simplistic approach towards ventilation, that we must aim at normal ventilation. The two and foremost goals are to prevent hypoxia and to target a normal carbon dioxide level ranging something from between 35 to 45 millimeters of mercury. Now let's look at a very interesting clinical interface, which actually we encounter in our clinical practice in day-to-day life. A patient, suppose, who comes with a severe traumatic brain injury and also got a cervical cord injury. So as we discussed, the first and foremost goal should be to prevent hypoxia and further cord injury in these patients. We should not aggravate the secondary injuries. So we must call for help. Because this patient already have a spine injury, we should be prepared for a difficult airway trolley and algorithm as appropriate to the institutions. Manual inline stabilization is something is highly recommended to be adopted for intubation in these cases. Now, what is this? Like in this photograph, as you can see, the patient head is kept straight in the midline by traction, hands on both the sides of the ears by an assistant which is standing at the head end. And caution should be exercised to minimize the movement of the head during the process of intubation. And we must also take steps or precautions to minimize stimulations, because in this process is usually very difficult if you have performed in the emergency unit or in the intensive care units. So you must take precautions to minimize stimulations. But if you are going to do a laryngoscopy in these patients, it is essential that we adequately sedate them, give them analgesics so that they do not struggle. And rapid sequence intubation should be followed as suitable and according to the expertise available in the unit. Now, regarding the ventilation therapies, to summarize, prolonged prophylactic hyperventilation is not recommended. So that is a moderate quality evidence. Early tracheostomy is advocated to reduce the number of ventilation days. However, it has been proven not to reduce mortality, nor it reduces the incidence of nosocomial infections. Now, what about the steroids? Now, among all the therapies or modalities of treatment that we will be discussing in the management of severe traumatic brain injury, it is probably one of the few or one of the very few modalities which have got level 1, that meaning by a very high grade of or high quality recommendations. The use of steroids is not recommended for improving outcome or reducing intracranial pressure. It has actually shown to increase mortality and is contraindicated according to the CRUSH trial. Next, one of the commonest therapies used in these patients is the hyperosmolar therapy. Now, these are largely two. One is the hypertonic saline, the other one is the mannitol. Hypertonic saline is available usually in two strengths, 3% and 7%. And mannitol is around in a 100 ml bottle of 20%, where one bottle contains around 20 grams. So the primary mechanism of actions are osmotic diuresis, whereby they drop fluid into the intravascular compartment and you cause diuresis. But the other more predominant and more effective for traumatic brain injury is that where they increase the intravascular volume and increase the microcirculatory blood flow to the brain parenchyma. However, they have their own complications or side effects associated. Regarding hypertonic saline, it is usually given in small fluid boluses of 30 to 50 ml over a period of 10 minutes to 30 minutes. And the desirable sodium range is around 145 to 155 milliequivalents per liter. One got to monitor the sodium levels very frequently, at least 6 to 8 hours if you are using the hypertonic saline on a patient. The dreadful complication remains in this patient is the central pontine melanosis, and this can arise if you're not regularly monitoring your sodium levels. Now, mannitol is also very commonly used in many parts of the countries, though it doesn't have a high grade of recommendation in its favor. And its diuretic effect is also undesirable in hypotensive patients or patients who have got acute kidney injuries. Now, let's remember that patients who have got polytrauma, many times they are hypovolemic, then under resuscitated with fluids, and they might also have various degrees of musculoskeletal injuries or rhabdomyolysis, who actually also can affect their kidney functions, causing acute kidney injuries. For such patients, if you're using mannitol, actually it will further worsen the status of the kidney functions. And it's also not recommended for patients who have got underlying cardiac dysfunctions. So let's look at the summary of our recommendation for this hyperosmolar therapy. Now, if you look at the analysis of the data and the trials, in the third edition, whatever was mentioned, they have restated those statements in the fourth editions because there was no new data to support their or recommend their therapy usage. Mannitol, it has been stated that can be used for control of raised intracranial pressure, but again, one has to take caution regarding hypotension. Regarding CSF fluid drainage, it is one of the common modalities again used especially for moderate to severe traumatic brain injuries, whereby an external ventricular drain is put in one of the lateral ventricles. It is attached to a manometer and then it is attached to a drainage bag. The leveling or the calibration is done at the level of the midbrain, that is an external landmark being the meatus, external auditory meatus. And when it is in the closed position, one can monitor the intracranial pressure, and when it is in the open position, it facilitates drainage of the cerebral spinal fluid. Now, regarding the level of recommendation for EVD, it is low quality evidence, and whatever they recommend, it is in favor of continuous rather than intermittent use. Now, just friends and colleagues, I have just a clinical scenario for all of you, and just to understand that what we have been discussing is we are able to understand that this is, let's go through the clinical interface, and I would request all of you to respond to this question. It might be a quick test to understand that if you're all awake and alert at this point of time. So I'll read the question for you. A patient with severe traumatic brain injury has got GCS7. I think he's projecting that as well. Also, cervical cord injury is demonstrated on CT neck. He has presented to the emergency department within 6 hours of the high velocity motor vehicle accident. Now, regarding use of steroids for cord injury, what will you prefer most? So these are the 4 options. I think we can have a poll, or if there's a provision for that, I'll wait.
D.
D, yeah. Anyone else? I think you can type in your responses, or there's a provision of poll if that can be done. Dr. Saad can tell us about that, or you proceed. Yeah, we have to show this question of the spine first, actually.
Is it the same one we have?
No. The same one, no.
Yeah,
yeah,
we have different one.
Yeah, different one. The cervical cord injury.
Okay. Yeah, I have this one.
Yeah, please put that.
Yeah.
Please go
You
for
can
this.
you can use the wall now if you wish. Thank you. Go ahead and click, please.
Yeah. I think most are going for option D. Yeah, so we proceed. I think that's a reasonable response, that as we have understood that the crash trial is actually almost conclusive, that steroids have an adverse effect for patients who have got severe traumatic brain injury. It is not advocated for use in these patients, even if they have got a cord injury. Can we stop this? Stop the poll? Or
Yeah, I think it stopped.
yeah, okay. So regarding infection prophylaxis, these patients, for a variety of reasons, have got increased susceptibility to infections because they have a prolonged length of stay in the hospital and in intensive care units. They're hooked to many pipes and catheters during their stay. And the VAP rate, that is ventilator-associated pneumonia rate, has been reported as high as 40% in these patients. And also there is a lot of invasive monitoring goes on along with the routine lines as for any other critically ill patients. Even ICP monitoring have related infections up to 27% reported in these cases. So there has been a lot of debate about the role of prophylactic antibiotics. Well, one school of thought proposes that it does reduce the infection rate, but there is a lot of evidence now that it actually increases the rate or risk of emergence of MDR, that is multi-drug resistant organisms, or XDR organisms. Regarding infection prophylaxis recommendations, so it's again a moderate quality recommendation that early tracheostomy is recommended to reduce the mechanical ventilation days. However, it does not reduce mortality or rate of nosocomial pneumonia. Regarding use of povidone iodine for oral care, again, it is not recommended. Instead, the chlorhexidine mouthwash is very good enough for oral care, and it is very imperative that we use it for our critically ill patients who are hooked onto ventilator to prevent the incidences of or reduce the incidences of ventilator-associated pneumonia, and oral care is to be given at least 3 times a day in each shift. Antimicrobial impregnated catheters may be considered to prevent catheter-related infections during EVD, but it has got low quality recommendations. What about deep vein thrombosis prophylaxis? I believe this is one of the most controversial aspects of care in neurocritical care patients. And without prophylactic treatment, actually, you see the incidence is as high as 54%. And if you're using the mechanical devices, the incidence is still high up to 25%. And they have a significant risk of venous thromboembolic events due to hypercoagulability state, which per se arises from the primary brain injury, because brain releases this thromboplastin, and which gives rise to, and due to the stress and the trauma, there is a hypercoagulable state. There is prolonged periods of immobilizations, and also there are other associated injuries may be present, like long bone fractures and other traumas in the body. So one has to be judiciously choosing between non-pharmacologic or pharmacological means to prevent DVT. The pharmacological means mainly includes the heparin, either low molecular heparin or standard unfractionated heparin. So there is a low quality recommendations for using heparin in combination with mechanical prophylaxis. However, it is heavily customized according to each patient profile and according to the disease state. Regarding seizure prophylaxis, these are mainly divided into 2 categories. Post-traumatic seizures are classified as either early, when it is less than 7 days of injury, and it is late when it is the onset is more than 7 days following injury. What is post-traumatic epilepsy is a distinct entity and is defined as a recurrent seizures more than 7 days after the injury. Now, the risk factors for early PTS, that is within 7 days, are a less GCS if they have a linear or depressed skull fracture, if they have a penetrating injury to the brain like gunshot injuries, if they have subdural, epidural, or intracerebral hematomas or contusion. So it's almost all kinds of intracranial or intracerebral pathologies with a low GCS actually predisposes or are risk factors for early post-traumatic seizures. And if they have added comorbid factors like chronic alcoholisms. Now, risk factors for post-traumatic epilepsy, that is arising after 7 days. Again, it is severe TBI, and if they have intracerebral hematoma or cortical contusions, and elderly patients. So look at that level of recommendation. You see the prophylactic use of phenytoin or valproate is not recommended for preventing late PTS. So there is no role of using these anti-epileptic agents for preventing late PTS. If there is no early PTS, that is post-traumatic seizures, there is no need of using this anti-epileptic drugs. However, phenytoin is recommended to decrease the incidence of early PTS within 7 days of injury. And now we increasingly see in the last 5 to 7 years at least, there is increased usage of this levetiracetam in head injury neurocritical care patients as an anti-seizure drug. Nutrition is part and parcel of general management of critically ill patients, and early feeding is actually good, at least after 48 to 72 hours of stabilizations. Enteral feed should be commenced to reduce the incidence of infections, be it ventilator-associated pneumonia or gut-derived sepsis. And adequate calories and proteins need to be instituted. There has been a long-standing debate about the role of decompressive craniectomy, because though it was performed for decades together, there was no good evidence or data on this decompressive craniotomy and the outcomes. And also the DECRA trial, which was conducted in the last decade, due to slow recruitment of patients over a period of 8 years around, it took long to conclude and arrive at the data. Now, how does it work? It is as simple as you mechanically removing a piece of bone to reduce the intracranial pressure. But mind you that by then already the cerebral parenchyma or the brain parenchyma is injured. There is edema, there is neural injury, there is axonal injuries, and just removing a piece of bone mechanically need not necessarily would reduce the intracranial pressure. And also there have been a wide variation in surgical techniques, timing, and the patient populations were offered this. So after all those trials, and the last one being the DECRA trial, it is recommended that bifrontal decompressive craniotomy is not recommended to improve outcomes as measured by Glasgow Extended Scale score at 6 months after injury in patients with severe traumatic brain injury patients where there were no mass lesions. The meaning being, if you have a localized mass like EDH, that is extradural hematoma, or a subdural hematoma, that got to be evacuated. But other than that, if it is a diffuse injury, if there is diffuse axonal injuries or diffuse a large contusion or hematoma, it not necessarily would give us any benefit. And recommendation is in favor of a larger frontotemporal parietal decompressive craniotomy compared to a small one, the minimum size being around 12 into 15 centimeters. Now, another aspect is about the hypothermia. Hypothermia again has been long talked about and frequently discussed in the management of neurocritical care patients. It is an established and accepted standard of care for neuroprotection in patients who have got out of hospital cardiac arrest patients. But in patients who have got traumatic brain injuries, there have been controversies, and hypothermia is actually not it's completely safe or not without risk. It does predispose to a state of coagulopathy, and these patients already being at a risk of either hypercoagulability or hypocoagulability due to DIC, trauma-induced DIC. So they further run the risk of coagulopathy. In addition, it can induce immunosuppression, thereby increases the chance of infections. They can precipitate cardiac dysrhythmias if the temperature is very low, promoting death. So early, that is within the first 2.5 hours, or short-term prophylactic hypothermia is not recommended to improve outcomes in patients with diffuse injury. Rather, in a practice, what we follow is we must prevent hyperthermia or aim for normothermia, something between 96 to 99 degrees Fahrenheit we aim. And certainly, if your temperature is going more than 100 degrees Fahrenheit, one should institute measures to reduce the temperature. Now, apart from this active treatment, these patients need to be very meticulously monitored in the intensive care units. So these are the 3 broad headings where we monitor, that is intracranial pressure, cerebral perfusion pressure, and advanced cerebral monitoring. Now, ICP and cerebral perfusion pressure, that is CPP, are of course closely related. ICP monitoring is a simple way of classification of 4 types. Interventricular one, where it is instituted inside the ventricles and it is brought outside and connected to a manometer, and then there is a drainage bag if it is also causing external ventricular drainage. Intraparenchymal, where the transducer is, or the parameter, the catheter is inserted inside the brain parenchyma. Subdural and epidural ones are not commonly practiced. Now, of these, the interventricular one is the commonest one, which is practiced for measuring intracranial pressures. If you look at this recommendation again, it is recommended to reduce in-hospital and at least short-term 2-week post-injury mortality. What is CPP? That is cerebral perfusion pressure. It is a very simple equation of deducting ICP, that is intracranial pressure, from mean arterial pressure. MAP, that is mean arterial pressure, is measured from an arterial line and it is set at the level of the heart. And ICP is at the level of midbrain or foramen of Monro, and external landmark being the external auditory meatus. Now, CPP monitoring is also recommended to decrease the 2 weeks mortality. Now, as a real life scenario, let's come to accept that most of the facilities probably may not having the facilities or the equipments for direct monitoring of cerebral perfusion pressure. What we can indirectly do in these setups, that we can go for a MAP monitoring by instituting an arterial line and maintain or target a MAP around 80 to 90 millimeters of mercury. And if your anyway clinical assessment or the patient's clinical status states that ICP is high, it will be generally ICP will be more than 20 to 22 millimeters of mercury. So you can just deduct it, and the CPP of desirable range, that is 60 to 70 millimeters of mercury, will be achieved. Now, to achieve that, one can use low dose of noradrenaline as required, but one should not be aggressive in this. Regarding advanced cerebral monitoring, these are mainly these 3 ones. Brain tissue oxygen monitoring, where oxygen status of the brain parenchyma is directly monitored. One can use transcranial Doppler and microdialysis as well. And also there has been talk about jugular bulb monitoring of the arteriovenous oxygen content differences. We just see this. So you can see this catheter is inserted inside the brain parenchyma, and it's like a pulse oximeter. Its oxygen status is being reflected on this screen, but it is mostly in the theoretical or the research arena, and there has been no recommendation on this. Advanced cerebral monitoring by using the TCD is very much in place, and it can be used to examine the arteries, the blood flow, the vasospasm mainly, and microdialysis to measure the brain metabolism, which looks at or states about the brain cells level of the glucose, lactate or pyruvate, etc. They're still within the research setting and not put to clinical usage. Regarding this jugular bulb monitoring of arteriovenous oxygen content difference, this can be monitored from the level of the jugular bulb, and the oxygen content difference between the artery and the jugular venous blood can be determined. It is again technically difficult, and it's not commonly performed or practiced. Now, few thresholds that we discussed are again corollary of what all the monitoring parameters that we just discussed are the blood pressure, ICP, CPP, and this monitorings. Systolic blood pressure, they say around 100 to 110. A map of around 80 to 90 millimeters of mercury. We should try to keep the ICP above 22 is recommended, because values above this level are associated with increased mortality. A combination of ICP values and clinical and brain CT findings will be used to make management decisions. So both ICP monitoring and clinical decisions have to be put together to make decisions regarding further intervention or change in management. CPP we have already discussed. The range is desirable between 60 to 70 millimeters of mercury. Now, secondary brain injuries are the important ones in nutshell, which must be prevented for best of outcomes. So our aim should be to prevent hypoxia, hypercarbia, rather aim for normocarbia. Painful stimuli are actually very important to be prevented in these patients, because any kind of painful stimulus or agitation increases their intracranial tension, and it is very difficult to assess because these patients are on various grades of sedation and analgesics. They may not express, but neurological status may deteriorate. These actually happen mostly during the sessions of suctioning or checking GCS when you're applying pressure on the supraorbital area, or during position change of physiotherapy. So this one has to be very meticulous and gentle in performing these procedures. And if necessary, before suctioning, some degree of sedatives or analgesics may be administered to make it a pain-free process. Hypotension definitely should be prevented, and hypo and hyperglycemia, that the both extremes of sugar level should be avoided. Patients who are already diabetic, their sugars go very brittle during intensive care management, and they need very meticulous attention to their sugar control. Sodium is one of the important electrolytes among all, which needs to be again followed thoroughly, and desirable ranges between 140 to 145 milliequivalents per liter. Hypo and hyperthermia, again, this extreme should be avoided. And in our practice, we tend to avoid hypothermia, at least aim for a normothermia. Especially in the context of these patients who have got traumatic brain injuries, who are in the ICU on ventilator, there are many causes of fever. It could be either infective and non-infective causes of fever. Infections usually arise subsequently if after a long stay due to nosocomial infections, but also one needs to remain watchful for non-infective causes of fever, where the list is really long, but the important ones I have just listed here for your attention. That is the brain injury per se, I remind you, can cause also rise in temperature. Blood in the ventricle. Similarly, if there are sites of deep vein thrombosis or pulmonary embolism, also mostly in the common ileopelvic veins, they also can give rise to fevers. Drug-induced fever is also one needs to keep in mind. Cases of aciculous cholecystitis have been found out when they have been investigated for non-effective fevers. Even basal atelectasis, if the lungs are not completely expanded, also can release interleukins and cytokines, which can cause fever in these patients. So in that context, we have to take help of these biomarkers and also simultaneously assess the patient clinically to rule out the sources of infections. One of the peculiar findings is regarding procalcitonin as a biomarker for this head injury patient is that it may not be raised in cases of localized infections, especially those patients who have this. And this is a consistent finding in our clinical practice. So the second clinical interface or scenario, just I thought I'll share with you, because many times we encounter this in our practice in patients with polytrauma. So Dr. Saad, can we go for this? It's a 40-year-old male with severe traumatic brain injury who has multiple rift fractures and a lung contusion on the right side. So chest is not good. He is on high ventilator support and high oxygen requirements. Lung compliance is poor. For a saturation of around 92%, he needs a PEEP of 10 and a FiO2 of around, I think, 60%. So what do you say? I think most of referred that they'll prefer PEEP of 6 and high FiO2. 57%. Oh, this is interesting. Right, followed by PEEP of 10 can be allowed in this patient to treat hypoxia. And the lowest percentage feel that high PEEP will contribute to high ICP. I think this is a very important question, a very common clinical scenarios in polytrauma patients who might have got a chest injury and a head injury. So now let me tell or share with you that if the lung compliance is poor and the patient has got trauma, ARDS due to the lung injury from the trauma, even if you're using a high PEEP of around 10, then that PEEP does not necessarily get transmitted to the intracranial compartment. So thereby meaning that this PEEP will not increase the intracranial pressure. So in this context, it's actually a risk-benefit ratio. I would say that if you're losing the PEEP, if you're reducing the PEEP, you're actually de-recruiting the lungs, and in the process, we are incurring the risk of having more hypoxia, and the lungs may not expand, and it might take a prolonged period to achieve the oxygenation goals and winning issues as well. So high PEEP in this kind of context where you're fighting for oxygenation goals can be allowed in these patients, while you can adopt other means to reduce your ICPs. Those who have, I think the highest people have preferred for PEEP of 6 and high FiO2. I would like to share my opinion that high FiO2, if you're using, actually, even if you're targeting an oxygen goal, high level of oxygen has got its own issues like free oxygen radicals and further propensitating the injuries to the lung parenchyma. And if you're not recruiting your lungs or not expanding your lungs with a positive end expiratory pressure, your ventilation is going to be affected. And in the process, the ventilation is not going to be adequate. So these patients, they need to be follow the pathway for lung protective ventilation as we do for any other ARDS. And high PEEP will not necessarily transmit to the brain, causing rise in ICP. This debate or the school of thought regarding transmission of high PEEP to intracranial pressure is more of theoretical than practical. We'll discuss it subsequently during the question answer session. So my response will be PEEP 10 can be allowed in this patient to treat hypoxia, because the consequences of hypoxia will be more consequential than reducing the PEEP and leaving the FiO2 high at 80 to 90%. So the take home message will be, to summarize, that GCS, Glasgow Coma Scale, I would say at presentation is an important determinant of outcome in severe traumatic brain injuries, because by the time the patient presents to the emergency department, he might have sustained the primary injury, but how the person is rescued and what is the time lag between the patient, the accident or the primary injury, and by the time the patient reaches the emergency department, in that time period also, he might have sustained secondary injuries. So these two together actually is going to have an important and direct bearing on the ultimate neurological outcome. So it is very essential to prevent the secondary injuries further once the patient has come to the hospital. Early intubation to secure airway and avoid further hypoxia must be practiced. It should be early and safe as appropriate, and with taking the cervical spine precautions. Avoid hypotension, do resuscitate them with good amounts of fluid, preferably the crystalloids, and prolonged prophylactic hyperventilation is no longer recommended. ICP monitoring should be done as when possible, but in resource-poor countries or resource-poor setups, CT scan and clinical examination, I would say, is good enough to treat these patients. CPP monitoring is again recommended. Again, you can do it indirectly by monitoring the MAP and keeping an eye on the ICP. If you have an invasive monitoring, well and good. Otherwise, you can clinically assess the patient for ICP. Barbiturates as prophylaxis has no role, but however, they can have a place in refractory elevated intracranial hypertension. Propofol is also not a good choice after a long 6 to 10 hours. Now, in polytrauma patients, we must take care of hypovolemia, hypotension, and hypoxia, especially if they have chest traumas, as we discussed that case, and pain. Adequate pain relief is of importance again. Suction-induced iatrogenic pain should be minimized. Infection care bundles like that ventilator-associated pneumonia or catheter-associated infections, soft tissue infection, all these care bundles have to be religiously followed. Early tracheostomy is advocated certainly to reduce or facilitate ventilator weaning. DVT prophylaxis, either of some sort, either mechanical and later on after 3 to 5 days, along with pharmacoprophylaxis, should be offered to these patients. And over and all, we should keep in mind about the futility of care in appropriate patients, like patients who are having GCOs 3, if they're nearing, started losing their brainstem reflexes, one must be alert and awake, alert enough to guard them and monitor them for brain death and do the needful. Thank you very much for your kind attention.
Thank you very much, Dr. Sharmili, for the lovely presentation. I have got some questions for you. Start with, sorry, 1 second. Yes, in your experience, what is the best method of endotracheal tube placement in case of traumatic brain injury?
Yeah, and that's a very common and very important practice that we perform in the emergency department. So as you know, the first dictum is all polytrauma patient, unless otherwise proven, we have to assume that the patient has got cervical cord injury. So you're putting the cervical spine. If the patient is conscious enough, I would say like mild head injury and moderate head injury, you're not going to protect their airways. But if you have decided the patient is offended enough or TCS is less, you're going to put a tube. You must take the C-spine precautions, that is manual and inline stabilizations. We have to procure good lines, give them fluids, the BP should be good enough, and we have to administer the sedatives, like some degree combinations of opioids and some like sedatives like midazole or benzodiazepines or propofol as permitted by the hemodynamics, and try to assess the airway. Airway should be clean. It should, many times these polytrauma patients have the debris or the blood clots in their mouth. Call for help, definitely. because these are very tricky. And once you think that if you have done a gentle laryngoscopy to see if the mouth is good enough and you can approach the vocal cords, you can go for a rapid sequence intubation using rocuronium. But by then you should be able to see that the vocal cords or the laryngoscopy has good grades. So I would say one has to be judicious and definitely call for help for these patients during the process of intubation to make it as smooth as possible.
Okay, thank you for that. Next question. Please enlighten on the shift of first-line anti-epileptics seen in recent years. Valproate replaced by phenytoin, which has now been replaced by levetiracetam.
Yeah, I'm glad that this question was raised. Actually, I myself was, in thoughts like the last BTF, that is Brain Trauma Foundation guidelines, were published in 2016, and it has 5 years have passed since then. And we are all clinicians or neuro-intensivists, we have witnessing greater use of levetiracetam in neurocritically ill patients. So I would say that one of the most common reasons that from my personal experience I gather is that the safety profile. Phenytoin, though it has been in use for decades together, more than 4 to 5 decades, we all know that it has got very sinister side effects possible when especially used in the long term. Like this gingival staining, it has got cardiac effects when it is given as a rapid bolus, and also it can cause liver dysfunction. And one of the very rarest, though hypersensitivity reaction, is a Stevens-Johnson syndrome. We have witnessed few cases of actually Stevens-Johnson syndrome caused by phenytoin. I think these are the issues, and also it's not safe in pregnancy for lady patients who are given more prophylaxis after or discharge from the hospital. If they're on phenytoin, it's also not safe for pregnancy. So considering the safety profile, I would believe that levetiracetam has gained popularity and it is more in use in practice. But I'd be inclined to see that it finds a place, or at least the Brain Trauma Foundation comes out with some kind of recommendation by analyzing the trials and the data on it.
Thank you very much for that. Is there still a role for Triple H therapy in severe traumatic brain injury?
No, I would say, because Triple H therapy, when we studied as residents and registrars, it was advocated in the case of subarachnoid hemorrhage. Even in those cases also, it is not no more advocated. It is only you have to maintain good hydration and pressure slightly on the higher side. But for severe traumatic brain injury, it is not recommended. The reasons, number one, I think as I mentioned in the initial slides, that if you're giving too much of volume, it actually causes hypervolemia and the cerebral blood flow increases. Once the cerebral blood flow increases, it actually increases the intracranial pressure because of that compartment, because brain is a tight compartment, right? So if you're just pushing more fluids into the brain and maintaining a very high pressure, which is not necessary, it increases cerebral blood flow and causes further injury to the brain.
Okay, thank you for that. Have you come across any case of neurogenic pulmonary edema in severe traumatic brain injury?
Yes, quite a few. Actually, quite a few we have seen. And actually, very recently, we had an old lady who had, she was in the step-down unit, and suddenly she developed pulmonary edema and came to the intensive care unit, got intubated. And this actually happened twice in her case. We explored all cardiac causes. There was even the cord, there was no stenosis, vocal cord stenosis, but at least twice she went into this pulmonary edema. So after excluding all cause, we thought it was mostly neurogenic pulmonary edema in these cases. But it can happen, and but not very common though.
Okay, thank you very much. Last question. Do we need to do TPP to decide the PEEP?
Say that again, sorry?
Do we need to do TPP to decide the PEEP?
What is TPP?
I think it's abbreviation. It's not clear, I'm sorry. It's just an abbreviation. So I think we can just...
I'll just go see that.
Ammar, can you write it?
Ammar, yeah.
Transpulmonary pressure.
Okay. Right.
Dr. Rabab, I have some question, please.
Yes, please, Dr. Isam.
Yes.
Should we just answer this one and then I can take your question? Is that all right?
Thank you.
You're very welcome.
Yes, thank you.
Yeah, let me, honestly speaking, we do not perform transpulmonary pressure to decide PEEP. It is actually, we adopt very simplistic approach for lung protective ventilation in any case for patient who is on ventilation, and especially patients who are on ARDS, because we have a protocolized approach. It is most applied to the nurses and the doctors and all consultants, everybody in the unit, for them to follow to ensure uniformity. And basically the goal of PEEP is for oxygenation. So it's a combination of FiO2 and PEEP to achieve your oxygenation goals. So set your goals, and we usually accept PO2 more than 60 or SO2, say in traumatic brain injury cases, more than 90 to 92%. So if that is achievable, we gradually go down on the PEEP and leave it something around 5 to PEEP normally. But transpulmonary pressure, we generally do not practice in all cases of ventilations. However, in few cases of difficult ARDS, like those are infection-related ARDS, other kind of cases, we sometimes go for transpulmonary pressure, but this is not a routine practice in my unit.
Okay, thank you for that. Dr. Assam, please go ahead with your question.
Thank you, Dr. Rabab. Really, today is very interesting because we listened to the one of the most informative lecture in the basic science from Professor Doyle. And we need this type of lectures many times to return back to our basic science. I have questions for both the speakers. I'll start with Professor Sharmili. You mentioned, Prof, no recommendation for using of corticosteroid and specifically methylprednisolone. But would you please explain why it is not recommended? This is first. The second one related to the hypothermia, not related to the hypothermia. I mean the target temperature monitoring, and it is complete difference between the hypothermia and target temperature monitoring. Is it recommended to maintain the patient with traumatic brain injury in the hospital in a constant temperature not less than 35 or from 35 to 36? Is it beneficial for the patient? The next question, forgive me for this because I'm interested in the neuro and of course this traumatic brain injury, one of the specialty. Is there any rule for the use of calcium channel blockers in case of traumatic brain injury and the magic drug magnesium sulfate? This is for Professor Sharmili. For Prof. Doyle, he mentioned a lot about morphine, and I heard nowadays and before since time that there is a great afraid of using morphine, specifically in USA. But the patient may have severe agonizing intractable pain, and he may need the use of morphine or the morphine derivatives. To my knowledge, I am not a pain specialist, but to my knowledge, as a patient has or complaining of pain, no harm of using of morphine. But nowadays, there is a great tendency for what is called pain-free therapy, morphine-free analgesia, or there is afraid of using of morphine. So please, can you explain for us why is this a great afraid, as we are controlling the morphine to be given to the patient? And I know this is afraid of the addiction, but there is a control of giving this morphine by the physician according to the state of the patient. Thank you so much.
Thank you, Doctor. Actually, very interesting questions you have raised. The first one I would like to take, and I think we did a poll on that also, about not using steroids in patients with severe traumatic brain injuries. Actually, this is the only recommendation if you look at the BTF, that is Brain Trauma Foundation guidelines, which has got a level 1, that is a high quality evidence. And this is actually has been arrived at after the CRASH trial, where they reported just little more than 10,000 patients, and almost equal number of patients who received methylprednisolone, and other group did not receive methylprednisolone, along with the routine management for traumatic brain injuries. And the death rate was significantly different between both the groups. I think something in the death rate in the steroid group was around something 25.7% versus I think 16 or 17% in the arm which did not receive the steroids. So because it was a well randomized controlled trial, and it was so significant, the difference in the death rate, so that was accepted, and it was, there was great consensus that steroid is harmful for patients who have got severe traumatic brain injuries. So these apart actually all the ominous side effects of steroids, as when we know from our users, is the hyperglycemia, the propensity to cause more infections, and hyperglycemia is an independent risk factors for brain injuries. So all this put together in nutshell, definitely steroids are not indicated, are not best of therapies for severe traumatic brain injuries. And number two, regarding, I think the usage of, you said about, the second question was, I think,
targeted temperature
channel
monitoring.
Yeah, regarding hypothermia. Hypothermia, again, they have all the trials that they looked at in the head injury patients, they were not of good quality data, and the maximum quality of data that they could generate is about level 2B or level 3. So it is concluded that it does not have any role in, because there was no difference in the neurological outcomes, but they were not again good quality trials though. So at best, whatever evidence is available, it accumulates to state that there is no role of prophylactic hypothermia on these cases. On the contrary, what arrives best or appeals best is to avoid hyperthermia. Because we have seen once the temperature starts rising beyond say 99 to 99.5 degrees Fahrenheit, these patients start getting tachycardia, they are agitated, and it becomes difficult to, and the metabolic rate increases and the cerebral metabolic rate also increases, and there is a direct relation with the neurological status. So in our clinical practice, we actually tend to achieve at least normothermia. If you say that hypothermia up to 36 to 37 degrees Celsius, one would be comfortable. But below that, actually, it has its own repercussions, like as it can precipitate cardiac arrhythmias. And mind you that these patients also might be having polytraumas. Polytrauma means like they might be having chest injuries, they might be having blunt trauma injuries, long bone fractures. So all these actually predispose to further coagulopathy, acidosis, dysrhythmias, and electrolyte imbalances also, which might increase the tendency for tachyarrhythmias. So all this together, I think there is definitely lack of data at this point of time to recommend a role of prophylactic hypothermia in traumatic brain injury patients. Definitely, it is proven for out-of-hospital cardiac arrest for patients who have got coronary artery disease. But as far as head trauma cases are going on, we have way to go there. Regarding the use of calcium channel blockers, they are obviously an accepted mode of treatment for preventing vasospasm in subarachnoid hemorrhage cases, also in traumatic SH cases, traumatic subarachnoid hemorrhages. But as such, for reducing intracranial hypertension for patients who have got diffuse injuries or even localized injuries, I do not think there is any role for this calcium channel blockers. And I think the fourth question, I don't remember.
Magnesium sulfate.
Magnesium sulfate actually would be a good way to explore. Actually, I'm glad that you raised it, and it would be a good subject for further research, because definitely it has a role in severe preeclampsia and eclampsia cases. And invariably, these cases, we are using magnesium sulfate for these patients. But how far it is, if this can be extrapolated to traumatic brain injury patients, I think we need a trial to prove this.
Thank you so much.
Thank you very much, Dr. Sharmila. I think now it's time to say goodbye. Thank you very much, our eminent speakers, for sharing your experience with us tonight. Thank you very much, everyone, for joining us tonight, and hope you enjoy the rest of your evening, and see you next time.